Welcome to the University of California, San Francisco Sports Medicine Podcast featuring Dr. Nirav Pandya, Dr. Brian Feeley, and Dr. Drew Lansdown discussing hot topics in sports medicine and society.
Welcome to our 6 to 8 weeks podcast. Drew Lansdown and I am here today. Nirav Pandya is off on Twitter discussing the fact that the 49ers will have no running backs next week when they play against Green Bay. However, they're still probably going to win. Today, we're going to cover a pretty important topic, how to interpret your MRI. With the Affordable Health Care Act, we all have access to our MRI reports. And in the past, you may or may not have gotten those reports, but now they're essentially standard to get. For sports medicine, shoulder is the one that seems to come up the most often as the one that patients need help figuring out what's normal and what's clinically significant, especially as we figure out what actually is the anatomic structure that is causing the pain in the shoulder. How do you interpret the rest of that MRI report? So it's great to have Dr. Lansdown here, since in addition to being a great surgeon and a diehard Green Bay Packers fan, he's also an expert in MRIs, how they work, and how to use advanced and novel sequences to get more information out of the typical MRIs. So welcome, Drew. I thought we would start today by having a little trivia for you. So the first question I have for you is, when was the first MRI actually performed and what was it performed for?
So I think it was done in the 70s. That's kind of when the technology was starting to be implemented. And I'm not sure why it was actually what the first study was done for.
Yeah, so you're absolutely right. It was July 3rd, 1977. So I was almost 3 years old. You weren't even born yet.
Not yet.
But MRI is actually a pretty new technology. It was started less than 50 years ago. So when you think about Xrays, which are over 100, CT scan, which is over 60, 70 years ago, MRI is relatively new. As with many things, cancer drove that technology. So there were a few scientists that came together and used magnetic resonance imaging, or MRI, to try to see if we could pick up cancer better than we could with CT scans. So my second question for you is, did the inventor of the MRI actually win the Nobel Prize?
I'm guessing no.
Yeah, so if you've been around clinic or when we do teaching, if the question sounds like that, absolutely, the answer is always no. So you're absolutely right. The MRI was invented by a New York physician named Raymond Damadian, but he didn't actually win it. So the Nobel Prize in 2003 went for the MRI technology, but not for the MRI technology itself, but for the ability to interpret the imaging coming out of the MRI machine and putting it in the pictures that we really view as those anatomic images that we interpret as our anatomy. And that was won by Paul Lauterbur and Peter Mansfield. And so you have a physician, you have a chemist, and you have a physicist, and it's those things together that really help MRI be successful. So this one's a little bit easier for you, hopefully, since you kind of got both of them. True or false? MRIs, because it's such a high power magnet, give you a lot of radiation.
So false. And one of the great things about MRI is that it does not have ionizing radiation. Like there are different types of radiation, but the ionizing radiation is the one that, we're really concerned about with causing cancer, other problems. So like if you're in a CT scanner too long, that type of radiation can actually put you at higher risk for cancer. Like one CT scan, a couple, not a big deal, but over time that can add up. But MRIs don't impart any of that radiation, which is great because then we can, get them more regularly if needed, or not have that, concern as we're getting those studies.
Yeah, and I think that's really important. So MRI is really safe. We're not exactly sure how it works. I'm pretty sure it's magic.
Some of us are.
So how does an MRI actually work?
Yeah, so it looks at the different composition of tissue, and probably most basically is like the hydrogen composition. So hydrogen is in water, it's in fat, and different amounts and different tissues. And that gives different property in the scanner. So when you're in the scanner, there's a big magnetic field that aligns all those molecules. And then you send little pulses of radio frequency, and it moves those molecules, and then you kind of record how quickly they come back to where they used to be, more or less. And it's those properties that are different in different tissue types and different structures that can give us that ability to see anatomic differences through the interpretation of it.
Okay, so you're saying there's little David Copperfields.
It's
inside,
just magic. Yeah,
inside every MRI machine.
Exactly.
And you're getting a magic picture.
Yeah.
Okay, great. So I think one of the things that comes up especially during the sports season, is the idea that we want to let an injury calm down prior to getting an MRI, that we need things to kind of reconstitute or something. Is there an ideal time to get an MRI as far as you're concerned?
No, I mean, I think my preference would be, there's really no role for something calming down. Like we can see, what those structures look like. And, sometimes even the swelling in the joint in the knee or the shoulder can really help define tears, other structures. There will be fluid that happens at the time of injury, and that can kind of define those areas better. But I don't think there's any need to, wait for something to calm down before we get an MRI.
Yeah, and I think that may have been true with the initial imaging, but at this point, I think it's actually better. So one of the things I tell my patients is that swelling acts as a natural contrast inside joints. So for me, like let's say you've had a shoulder dislocation, you will have bled and gotten swollen inside the joint. So that acts as a natural contrast agent, or something that typically, if it was a chronic injury, we would be injecting contrast. So it saves you a needle injection. And the anatomy is still the anatomy. Even if it looks beat up, it's going to look more or less similarly beat up 1 week, 2 weeks, 5 weeks after the injury, except for some really rare circumstances. PCL tears, for instance, actually reconstitute over time.
But I was kind of thinking the same thing, because that initial image can look different, and then you can get a different view of it maybe 6 months, a year later. And sometimes we'll even, if you've had that MRI right after the injury, sometimes we'll even get one a year later to try to see like how things have changed, how they've healed or not healed in some situations.
Yeah, absolutely. So, the next thing is, when do we get MRIs? And I think one of the important things is, oftentimes when patients come into clinic, they'll say, well, I don't want an MRI, or sorry, they never say that. I don't want an X-ray. I want an MRI, or I've already had an MRI. Why do you want to get an X-ray? So especially for the shoulder, what does an X-ray tell us that an MRI doesn't?
Yeah, so the X-ray gives us a lot more information about the bony structure. And then so the X-ray is a 2-dimensional projection. And then the MRI, we see like 3-dimensional slices across the structure. And kind of that like global image, I think, is really useful as well to understanding how the joint is working. But for some conditions like arthritis, especially, the X-ray can give us a lot more information about, the narrowing of the joint, and then just the overall structure of the bone. And then also with X-rays, we can, we'll routinely get one where the patient's holding like a small weight, like a 1-pound weight. And that just tells you how that joint is working with a little bit of load on it. So that tries to get the rotator cuff to work. And if your rotator cuff isn't doing its job, then we'll see different findings on the X-ray. And it's almost, complementary information to the MRI. So I think they both have a role, both really help. And it's, even though the MRI gives you more detailed information, what we get out of the X-rays, I think sometimes can even guide our treatment even better.
So I'm going to go through how we like to read and interpret these MRI findings that a radiologist reads. So this is an example of a 65-year-old with shoulder pain. So for this, you can see that the report is broken down into essentially anatomic structures. The acromial outlet, which is the area underneath the acromion, or the top part of your shoulder that you can feel, the rotator cuff, the labrum and capsule, biceps tendon, the bone and cartilage, and then everything else. So the way a radiologist reads this, which is great, is it's an unbiased view of what everything looks like. They don't really know the clinical story, and they are just looking for anatomic differences, not even changes. And they really try to limit the interpretation, and they leave that up to the clinical part, which is when you see your physician or surgeon. So when I look at this first, I see moderate arthrosis at the acromioclavicular joint and trace subacromial and subdeltoid fluid. So that's actually a pretty normal finding. Your acromioclavicular or AC joint actually starts breaking down around age 38. So in a 65-year-old, that's entirely common. So even seeing severe arthrosis or degeneration of the AC joint is a normal finding unless you have a lot of pain right at the AC joint, which we sometimes see in people who are 30 or 40 years old and do a lot of strength training. Similarly, trace amounts of fluid anywhere is often physiologic. If there's a moderate amount of fluid in the subacromial space, that's usually consistent with impingement or a larger rotator cuff tear, but a trace amount of fluid is pretty small. Now, probably the most important part of this is the rotator cuff evaluation. And certainly for a patient like this, we're often looking for the presence or absence of a full thickness tear. So a full thickness tear is essentially a hole in the rotator cuff where the part of the entire tendon is not attached. It doesn't mean the entire rotator cuff isn't attached. It means that only a part of it is attached. And when it says without retraction, that's actually meaning that it's torn off, but it hasn't really gone anywhere. So overall, this is still a pretty small tear, even though it sounds pretty bad. Now, the background of tendinosis, which we see both with the supraspinatus or the rotator cuff on the top and in the subscapularis where it says tendinosis, is essentially a MRI finding of collagen disorganization, which is usually a age-related change. And it's not something that we can either see at the time of surgery, nor is it something that we necessarily want to be very aggressive about treating. There are some physical therapy suggestions that reorganizing collagen will decrease the amount of tendinosis, but it may be part of that normal breakdown and remodeling that all your tendons do. Now, atrophy and fatty infiltration, which is often one of my favorite topics when it comes in the setting of a rotator cuff tear, it can be really clinically important. However, when we see it in the teres minor, it's often an incidental finding. So the teres minor is the smallest rotator cuff muscle. It comes off the lower part of your scapula, and seeing some atrophy and fatty infiltration, especially as we get older, is actually pretty common. And I think the hardest part to figure out for a lot of patients is why they're having tearing of their labrum. So if you look up a labral tear, there are really 3 to 4 different types of flavors of labral tears. The first is an anterior labral tear, and that's when you have a shoulder dislocation. Second is a posterior labral tear, which you can have if you have a posterior shoulder dislocation, which is pretty uncommon. And then you can have a superior labral tear, which is where the biceps attaches, and it's called a slap tear for superior labrum, anterior and posterior. If you are a young throwing athlete or a swimmer, volleyball player, tennis athlete, then having a superior labral tear can actually be a symptomatic thing. As we get older, and by older, I mean over the age of 30 to 35, you actually get a pretty significant you're pretty likely to have a superior labral tear. And it's not necessarily tearing, but more degeneration. And it's actually a normal finding. So over the age of 50, probably about 95% of people will have degeneration of the superior labrum. So in this patient particularly, I'm not worried about the superior labral tearing. So this is not something that we would consider important. Similarly, for the biceps tendon, any intra-articular changes, unless it's tearing of the biceps, we're not too concerned about. We're much more concerned about this extra-articular portion of the biceps that can often lead to anterior shoulder pain. Now, when we look at the bones and cartilage, it's actually important to know that X-rays are more important and more specific for evaluating the amount of arthritis that you have in your shoulder. MRI is great with soft tissue, but it's not so great with bones and cartilage. So when it says that there is heterogeneity, that just means we see different types of signal within the glenoid cartilage or the socket of the shoulder. With subadjacent sclerosis, that means the bone's a little bit harder. That may have little to no actual clinical meaning whatsoever, or it could mean you're at the very, very, very early stages of having arthritis. Having small inferior osteophytes, similarly, if they're very small, suggests that your bone at some point has seen some different amount of load and you've formed a tiny bone spur, which can be essentially almost normal for age, or it can mean that you have the early development of arthritis that's going to take years and years to actually show up over time. Synovitis in the rotator interval. Synovitis is the lining of your joint with the synovium where it gets a little bit inflamed. So this we can see in the setting of frozen shoulder, or it can be non-specific where it just shows the shoulder is a little bit irritated. So we often will see this with early arthritis, with rotator cuff tears, or with an acute injury. So it's not something that we're really worried about unless we see it in the setting of a dramatic loss of range of motion, which even the radiologist points out, which can be seen with adhesive capsulitis or frozen shoulder. So when I look at this, and it's important to also know that most of the time, almost all the time, unless it's not available, I'm going to look at the actual images first before I look at the report, because I want to judge it based in the clinical scenario. Most of these changes are normal for age. So arthrosis for the AC joint, totally normal over the age of 40. Atrophy and fatty infiltration, not relevant and normal as we get older. Degenerative tearing of the labrum over the age of 40 without a dislocation event. Again, I'm not concerned about. What I'm most interested in for this is the full thickness tear of the supraspinatus. And that's really what's going to guide treatment for me, because depending on the patient's age, activity level, pain, and what they've tried already, this is going to dictate whether or not they're going to benefit from surgery or physical therapy or other interventions. So I think that gives a good example of how we go through an MRI. I just have a few other questions before we wrap this up. So do you want to describe when you would use an MRI to assess healing? Do you think it's a good tool, great tool, tough to use? And why don't we just get an MRI on everybody to come in to assess healing?
Yeah, good question. And I think it's tough to use. And, whenever you've had surgery, the images will always look different. And you may see like fluid or changes, but it may just be that, that tissue had surgery on it. And so it doesn't look like, a completely normal tendon, completely normal ligament or meniscus or whatever it may be. And so it can be hard to say on MRI alone, like, okay, that looks perfect, we're good to go. Or, I'm concerned, I see some fluid there, because it may not be problematic. And so I think the best way to judge healing is really like symptoms and how the joint is functioning, checking its function, seeing if it's able to, tolerate activity and load, and then using the MRI after surgery if there's a problem, because then you can help distinguish like, okay, is this lining up with the problem that they're having? But what do you think?
Yeah, I tend not to use it. I will actually use, for instance, for rotator cuff problems, I will use ultrasound, because I think with ultrasound, it gives us a dynamic evaluation. And what I'm really looking for is tendon present or absent at bone. If it's present, great. I think an ultrasound is just as good and tends to give us lower resolution, but better fidelity. And ultrasound is dynamic. It allows me to have the patient move back and forth, which an MRI doesn't. And I think if you have a good ultrasound tech and good radiologists that know how to interpret it, I think an ultrasound for a lot of things is actually better. I'd be remiss without mentioning that I do think there are some things that an MRI is really good at. And I think as we've gotten better with understanding how we can use the whole MRI, it can help us figure out how to predict how patients are going to do. So for instance, you can score the entire joint, like how healthy the entire joint is, and use that to predict how patients may do after rotator cuff repair or after a shoulder replacement. And I think as we've gotten better at understanding these advanced imaging capabilities, we can do things like, rather than just say, well, there's some fat in the muscle, we can actually quantify it and come up with thresholds where we say, I think with this amount of fat at 5.8% of your muscle being fat, you may do better with this type of treatment, or we may need to augment treatment. And I think the next step for MRI is really being able to use those quantifications to figure out these patient-specific treatment strategies to know when we need to augment repairs or when we need to go slow with rehab. I think next time we'll cover knee, because I think that's really interesting, and you're doing some great research in how we use graft health and graft recovery to know when people can get back on the field or get back to duty or get back to work. So I'm going to finish up today. So, Drew, thank you very much for getting an A+ in your MRI trivia. But we understand that it still is just magic, and that's how MRI works.
That's the main takeaway.
All right. Thanks. Hopefully this was helpful for everybody. And Nirav, good luck finishing your cases.